Okay, we better get started. So lunch is at 12:15, so we'll just get through what we can and then adjourn it promptly at 12:15. And someone had asked me about the falls, and you clarified it for me. I don't see her. So the falls, the TBI and falls, according to the 2013 CDC, falls is the leading cause, 47%, followed by being struck by something like a bat, 22%, and motor vehicle accidents, surprising, 19%, according to the CDC. So, okay. Pardon me? Okay, got it. Okay, we're going to do psychopharmacology, and we'll focus in on the second generation antipsychotics first. Let's see. Well, here it is. Okay, so for EPS, of course, acute dystonic reaction, early onset affecting young males often, pharyngeal or tongue constriction or movements, oculogyrate crisis, don't see that very much anymore, or torticollis, don't see that much anymore. Treat with 2 milligrams of benztropine IM. I'm assuming there'll be questions like this on the test. Akathisia, so inner restlessness, usually restlessness of the lower extremities. It's important to differentiate that from the agitation that you often see with mania and psychosis. The way you differentiate it often, or at least I differentiate it often, is if they're uncomfortable. And they'll tell you, gee, doctor, I feel like there's a motor running inside of me and I can't stop it. And they'll try to sit down. They'll sit down for a few minutes and then be unable to stand or be unable to stay seated. Okay? And you treat with propranolol, generally 10 to 20 milligrams POTID. Then with propranolol, watch out for the bradycardia that you can often see with it. Okay? And antipsychotic-induced Parkinson's. So classic Parkinson's syndrome, the neurologists complain that they can't really tell the difference between antipsychotic-induced Parkinson's and spontaneous onset Parkinson's. Okay? And remember, it often takes 72 hours after starting or increasing the dose in order to see an issue with it. Okay? Because it takes that long to fully block the dopamine receptors. And so you can treat it with anticholinergic meds, usually benztropine. And it's questionable whether that's successful if you have a significant Parkinsonian reaction. Oftentimes that doesn't work, and you often have to lower the dose or change the medication to a medication that causes fewer of the side effects. Okay, so for instance, if somebody's on Haldol, they'll often have issues with their Parkinson's. And if I often have patients on Haldol because nothing else seems to work, sometimes not even Haldol. So then I have to check them carefully all the time. And it's amazing how often I see the tremor, a little cogwheeling. Sometimes it's very serious. Sometimes they go into a full-blown Parkinsonian reaction. And then if it's serious, then I have to go to another agent. Cogentin usually doesn't work. If it's just a little tremor, a little cogwheeling, and not complaining about it, then my benztropine will work at that point. Okay, late onset. Tardive, of course, refers to tardy, late in coming on. So late onset dyskinesia with classic tongue movements, and you look at the tongue, you distract them. I have them touch their thumb to their fingers. And so I'm distracting them, and I try to look at their fingers, and I tell them open their mouth, and then I may be able to see the vermiculiform movements, the worm-like movements. Okay, and then be careful if they have problems with their teeth, or they're wearing dentures, or they're not wearing dentures. Often, if they're not wearing dentures, then it's very difficult to tell because they'll have movements of their mouth, lips, and tongue in that case too. So what I'm looking for is the vermiculiform movements. You can have it of the extremities too, but that's a little more unusual. Okay? Now, TD generally comes on several years after you start the antipsychotic. Now, I always thought, though, it could come on 4 months after you start the antipsychotic, but some people are reporting earlier times, like up to 2 months. So it's possible to see it relatively early in the course, but that would be rather unusual. Can be irreversible, but I tell my patients, always tell me when they first notice there's a problem so that I have a chance to intervene and change the medication around before it does have a chance to become irreversible. Change to quetiapine or clozapine if practical, But if you have a very serious psychosis, sometimes we question how effective we're going to be with quetiapine. The risk factor then is older age. I'm assuming because they'd be more susceptible to all kinds of neurological conditions and brain injury. Females seem to have a higher risk of it, higher dose of medications, other EPS symptoms. Now, we do have a medication that does treat tardive dyskinesia, which is valbenazine or do-tetrabenazine. So remember those. And then, but they're difficult to get. I don't know if anybody's been able to access them.
No, we haven't, because it's so expensive.
They're so expensive, and you just can't order them through the pharmacy. You have to contact the company and have them provide them to you. And then we've had a few people on them. I haven't in the department, and they're talking about they get profoundly flat because it depletes most of the neurotransmitters, and only in that way can they reduce the tongue movements. Okay. So neuroleptic malignant syndrome, that 2% may be a little high, even with the older medications. I think Paul Keck said that I think it was 2/3 of 1% that he saw neuroleptic malignant, the manifestations of NMS. Okay, so the increased risk with IM injections, long-acting injections, that is, because in that way you know that they're getting it, or rapid dose increase. The symptoms are a fever, and almost always is 101 over or above. And you really watch for that. If they don't have a fever of 101, I would question the diagnosis. Certainly I would check them out, but if they don't have a fever of 101, I would still be concerned, but that would question the diagnosis for me. Altered consciousness, extreme rigidity. So those patients, thankfully those few patients that I've seen have NMS, even though I prescribe a ton of Haldol, they are profoundly rigid. Sometimes they're so rigid, they'll have a dorsiflexion of the feet, and the orthopedic surgeon will have to cast the feet so they won't have a permanent, plantar flexion. Okay. CK is often over 1,000, and that's, at least in my mind, that's controversial. We're always getting CKs on these people, and in our hospital, and I'm assuming your hospital too, the cutoff is 250. Well, if we're truly seeing NMS, it should be 2,000 or 3,000. And so I usually don't worry about it if it's 650, as long as I'm not seeing other symptoms of the illness. Okay. We've already talked about this. It can cause rhabdomyolysis and renal shutdown. And the important thing there is to give IV hydration to try to keep the kidneys going. And sometimes it seems like we can preempt the full manifestations of the NMS with IV hydration. Okay, I seem to see at least one.
I'm not sure. I've used bromocriptine and dantrolene. It's not clear that it's effective.
No, I would agree with that. It's never.
It's in the literature, though.
It's in the literature.
It's in the literature, but yeah.
Yeah. So from a test standpoint, bromocriptine and dantrolene sodium would be the appropriate treatments, along with all the other things. Of course, stop benztropine. If you go on to the point of neuroleptic malignant syndrome, the benztropine is no longer going to work. It probably just complicates things further. Okay? Cooling blanket, and we've already talked about the bromocriptine and dantrolene. Now, serotonin syndrome, I thought you might be called on to differentiate serotonin syndrome from NMS on the test, so I put these together. So you have flu-like symptoms, GI symptoms, and cardiac symptoms, and possibly some mental status changes. Now, rare progression to delirium, hyperpyrexia, and further complications. Increased severity with an overdose of SSRIs or SSRIs plus MAOIs or a combination of serotonin agents. So we do at times suggest combinations of agents, but then be careful to maybe use Wellbutrin along with the serotonin agent. Wellbutrin, of course, doesn't affect serotonin. If you use the two together, you run the risk of a serotonin syndrome. Yes?
I think you developed it on lithium. I didn't know it would be
Serotonin syndrome?
yeah, you had it talk
I think you probably have something else going on there.
No, it can't.
Really?
There's a whole laundry list of medications that can affect serotonin
Okay.
that aren't necessarily serotonin.
Okay. I still wonder about that one.
They won't be on there.
I wouldn't think so. I'll have to look that one up further. Okay?